Morning, everyone. I'll be presenting on behalf of Medicine 3 Matters of the Heart. I'll be actually presenting five patients, quickly presenting five patients. So, case one, 77-year-old female with weakness of upper limb and lower limb for 2 days, breathlessness for a single day, background diabetic, and a hypertensive. She actually presented hypoxic, tachypneic, and tachycardic. She had a pansystolic murmur, which we heard in the mitral area. She had bilateral crepitations. There was hepatomegaly, which was with a lever span of around 14 centimeters. She had left upper and lower limb weakness of power of 4 by 5. The second case, a 38-year-old male from Jharkhand with fever and cough for the past 3 months, breathlessness for the past 3 months, known rheumatic heart disease for 25 since 25 years, and was underwent a mitral valve replacement for the same. Again, in this patient, we've heard he was hemodynamically stable. He had an MDA murmur in his mitral area and a PSM in his tricuspid area. Minimal crepitations that were heard bilateral infrascapular area. JVP was not elevated. There was no pedal edema. He was not in distress. There was no hepatosplenomegaly. There were no neurological deficits. Case 3, a 30-year-old female from Ranipet with cough for 1 month and palpitations for the past 10 days. There were no known comorbidities for her. She had come in tachycardic at a heart rate of 134. Otherwise, her other vitals were normal. She also had a pansystolic murmur, which was present in her mitral area. There was no hepatosplenomegaly, and her neurological examination was fairly normal. The fourth patient would be a 41-year-old male who has had an old CVA and also has had hypertension. He came with 45 days history of intermittent low-grade history of fever, cough with expectation for the past 1 week, new onset speech difficulty for which he came to us. He was tachycardic. His GCS on arrival, he was actually confused. He 14 by 15. Otherwise, apart from his speech, his neurological exam, because of the disorientation, there was limitation for doing it initially, but he was moving all four of his limb. There was no hepatosplenomegaly. Again, we had appreciated a pansystolic murmur in his mitral area here. Uh, Fifth case, a 63-year-old male from Kadapa. He had come with decreased movements of all four limbs since the past 2 months and cough since the past 2 months. He's been a diabetic and a hypertensive since the past 2 years. His initial GCS was only 12 by 15. He had a pallor and clubbing. He also had a systolic murmur in his mitral area. There was splenomegaly. He also had left medial rectus palsy. Right upper and lower limb power was 3 by 5. Left was only 2 by 5. Just I know there were too many things that was there right now. Very sorry. All five cases together. Just so the first case presenting with weakness and breathlessness for acutely, fever, cough, breathlessness for 3 months in the second case. Third case presenting only with cough and palpitations. Fourth case, fever, cough, speech difficulty since past 1.5 months, and the last one with decreased movement of all four limbs and cough since the past 2 months. So in the examination, if I would like to draw a common denominator here in all of them, we were able to appreciate a clinically significant murmur on examination for all of them, in all of them. So I'd like to speak about infective endocarditis. We've been getting a lot of cases since the past few months. We just wanted to go through this. So one thing I just wanted to highlight again here is atypical presentations of infective endocarditis, presenting as a stroke, presenting as back pain or vertebral osteomyelitis, isolated heart failure, or as hematuria itself. So whenever we have a patient with a suspected native valve IE, we first do a blood culture based on take the history, examination, blood cultures, followed by a transthoracic echo. If it fits into the criteria, we can go ahead and treat. And if it is possible, then again we repeat blood cultures, or we have to do a repeat TTE bara transesophageal echo at 5 to 7 days. There are recommendations for CTA as per the European Society of Cardiology. However, most of our patients end up having AKA, and we usually do not end up doing it. So again, for our patients, all five patients, one was culture negative. The others, two of them grew coagulase negative cons. One had grown Enterococcus faecalis. One had alpha hemolytic streptococci. Sensitivity pattern, we had it was MSSA for one of them. The last patient, unfortunately, it was awaited. The third one has the it was pan sensitive, and case for 4, vancomycin and ceftriaxone was sensitive. Transthoracic echo itself picked up the vegetations for 3 of these patients, while 2 of these patients actually required a transesophageal echo. Thankfully, none of our patients required a PET scan or a higher imaging for picking up these vegetations. So, of course, the early critical phase is within that 10 to 14 days. At this point of time, if there is a significant abscess or a vegetation, we should be, if there is an indicated surgery, that has to be done. Rapid bactericidal combination should be started. And if there is an abscess, it might actually warrant draining of abscess. So course for the 5 patients here. Initially, the first patient, the 77-year-old female, actually she on arrival and as on evaluating, we found out that she has an ACS, and unfortunately in the ward she progressed to have another embolic stroke. Her acute kidney injury worsened. Then she went into pulmonary edema. In view of her age and multiple comorbidities, family did not want to further pursue care. Case two, he was admitted. He was started on antibiotics. He also developed an NSTEMI during the treatment in the ward. Later had an embolic stroke in the ward. He was immediately transferred, and he underwent thrombectomy for the CVA. After receiving 6 weeks of antibiotics, he has now undergone a mitral valve replacement at this point of time. Case three, she is the young lady without any comorbidities who's come. She actually developed heart failure in the ward, which settled with minimal diuretics. She's now currently still receiving her antibiotics, but she did develop venous thrombosis secondary to a long life. Case 4, she had a new onset CVA. Unfortunately, he then developed hemorrhagic transformation secondary to the same. He required, because of raised ICP, he had a hydrocephalus, then he required an EVD, and then later worsened to have an intra-abdominal bleed, and he passed away in the ICU. Case 5, again, in view of his age and other comorbidities, family has opted for a further care in a nearby hospital. So if you look at it, most of them end up having multiple complications in the form of cardiac, pulmonary, neurological, or renal, or having other septic emboli. So just quickly mentioning about the trends in infectoendocarditis. This is a paper published from CMC Vellore itself. So we've had so most of the patients predominantly tend to be male, and there has been a trend change. Slowly there is more and more of native valve endocarditis which has been going up. The most common organisms that we pick up are strep more than staph, followed by enterococcus and gram-negative infectoendocarditis. However, the study done in PJ Chandigarh is not the same. They have much more of Staphylococcus aureus, more than strep, and also they have a lot more of injection, IV drug abuse related infectoendocarditis. This is more recent study done from Mumbai, which is also showing something similar itself, but they have slightly more of gram-negative infective endocarditis also. So the thing was, if you look at the entire thing, there was 3 of them who had poor prognosis, 2 of them who had good prognosis. The average cost of such patients and duration of stay is quite high. And the fact is, most of our recent patients have been all having native valve endocarditis. So the outcomes are dependent on comorbidities, higher age, heart failure, larger vegetation status, persistent bacteremia, neurological complications, or other complications. So we just wanted to highlight the fact that infective endocarditis has varied presentations, multiple complications, has high cost of admission and long duration of stay. We have to have a high degree of suspicion early to get a definitive diagnosis. Thank you.
Thank you, Dr. Ritesh. Are there any questions from the audience? So what specifically in these patients do you think, or rather moving forward, what do you think people should look out for to make a diagnosis of infective endocarditis?
The one is clinical examination. The murmur, if we hadn't picked up the murmur, again, we would have, the initial lady had a very acute onset symptom alone. It could have been easily missed out on as a stroke with an aspiration pneumonia. If we didn't think of the murmur, if we didn't pick up the murmur, we wouldn't have chased behind it. That is something we can always fix it on. The other patients didn't clearly have a fever. Few of them didn't have fever, but still had a clinical this thing. So it should be thought at the back.
So was other than the one had a valve replacement, but the others already have rheumatic heart disease, or
No,
was the
no,
murmur all new?
no. None of them have a past history of rheumatic heart disease. All the other
So it
five
was
patients.
native valve on a normal valve.
This one.
How many of these had fever? Only two.
One of them, so one of them was two of them from our hometown, Vellore, Ranipet itself. One was from Ranipet, one from Jharkhand, one from Kadapa, and one from West Bengal also. From this January, sir. That it's not necessary that all of our infective endocarditis patients have fever, and initial presentation of pure stroke itself should be, if we don't think of it as a differential, it is not, won't be thought of, sir.